Welcome, curious minds. Today, we're taking a deep dive into a system that truly slumbers for years before bursting into life, the human reproductive system.
That's right.
We're pulling out the most important insights from Chapter 27 of Human Anatomy and Physiology, 10th edition, to give you, well, a shortcut to understanding this intricate part of us.
It's a fantastic chapter.
Think of this as your guide to not just what these organs are, but, how they function, regulate themselves, and even develop right from the very beginning.
Yeah.
We'll explore everything from those microscopic sperm factories to the grand hormonal orchestrations that define our lives, sprinkling in some surprising facts and key clinical takeaways.
It really is a fascinating area. It shows how biological knowledge isn't just memorizing parts, right? It's about seeing the deep interconnectedness.
Exactly.
We'll look at the core reproductive organs, their essential supporting structures, and the powerful hormones that influence so much more than just the ability to create new life.
Get ready to connect some dots, because we're about to unpack how two distinct systems work together for one common, incredible purpose: the continuation of our species.
Let's dive in.
So let's start with the fundamental question. What is the reproductive system's primary mission?
Well, unlike other organ systems that work tirelessly from birth to keep us alive and functioning, the reproductive system has one unique purpose: to produce offspring.
Okay.
It seems to slumber through childhood, activating only at puberty for this specific vital role.
And what are the main players in this specialized system? Who's doing the heavy lifting?
The central players are the primary sex organs, also called gonads. So that's the testes in males and the ovaries in females.
Right.
These are absolutely crucial because they're responsible for producing the sex cells, or gametes, sperm for males and eggs, or ova for females.
Yeah.
And they also secrete the steroid hormones, known as sex hormones, that drive so much of our development and function.
And everything else is accessory.
Pretty much. All the other structures like the ducts, glands, external genitalia, they're considered accessory organs. They just help get the job done.
So the male's role is essentially to manufacture and deliver viable sperm.
Right.
And the female's is to produce the egg and then uniquely provide the protected environment for a developing embryo.
Exactly. And these sex hormones, androgens like testosterone in males, estrogens and progesterone in females, they're vital not just for reproductive organ development and function, but they dramatically influence sexual behavior, drives, and even impact many other body tissues. They really shape who we are.
Okay, let's unpack the male anatomy first then. From those sperm-producing tests to the elaborate delivery system.
That's good.
Let's talk about the scrotum. This sac of skin, it hangs outside the body. Why is this seemingly, vulnerable location absolutely essential?
It's an incredible adaptation. It really is. See, viable sperm cannot be produced efficiently at core body temperature. Our standard 37 degrees Celsius is actually too warm.
Too warm.
Yeah. The scrotum's superficial location provides a temperature that's about 3 degrees Celsius cooler, which is optimal for sperm viability.
Wow. And it even has its own built-in climate control rack.
Absolutely. It's quite clever. When it's cold, muscles like the dartos muscle wrinkle the scrotal skin, and the cremaster muscles pull the testes closer to the body to conserve heat.
Okay.
Conversely, when it's warm, the skin loosens, the testes drop lower, increasing surface area for cooling.
And there's that vein network, too.
Exactly. The pampiniform venous plexus, it acts like a sort of built-in cooling coil, absorbing heat from the arterial blood before it reaches the testes. Really neat.
So inside these remarkable tests, what are the actual sperm factories?
Okay, so inside you find these compartments, about 250 lobules, each packed with 1 to 4 tightly coiled seminiferous tubules. These are the sperm factories.
Seminiferous tubules.
Got it. And within them are the spermatogenic or sperm-forming cells. They're embedded in these larger cells called sustenticites.
Sustenticites. And what are these doing? Are they like nurse cells for the sperm?
Precisely. That's a great way to think of them. They are supporting cells that act like nursemaids. They provide nutrients, help move the developing cells along, secrete fluid for transport, and clear away any faulty sperm cells.
Cleaning crews, too.
Yeah, exactly. And then surrounding these tubules are the interstitial endocrine cells, or Leydig cells. These are the ones producing androgens, primarily testosterone, that crucial male sex hormone.
So sperm production and hormone production are separate jobs, different cells.
That's right, done by distinct cell populations within the testes.
Any clinical considerations for the testes that, our listeners should be aware of?
Yeah, it's worth mentioning. While relatively rare, testicular cancer is the most common cancer in young men, say, aged 15 to 35.
Okay.
The key takeaway here really is awareness. A painless solid mass is the most common sign. Early detection, often through self-examination, leads to an impressive cure rate, often over 90%.
That's encouraging.
Definitely. And conditions like cryptorchidism, where the testes don't descend properly during development, significantly increase this risk.
Right. Okay, moving on to the penis, the male copulatory organ. Inside, it contains the spongy urethra and these three long cylindrical bodies of erectile tissue. How does erection actually work?
Okay, so during sexual excitement, it's a parasympathetic reflex. This causes the local release of nitric oxide, or NO.
Nitric oxide, okay.
Yeah. NO relaxes the smooth muscle in the walls of the penile blood vessels, causing them to dilate. This allows the vascular spaces within that erectile tissue to fill with blood.
Right.
That engorgement makes the penis enlarge and become rigid, and that's an erection, enabling it to act as a penetrating organ.
And what about common issues like erectile dysfunction or ED?
Well, ED, the inability to attain an erection, affects surprisingly about 50% of American men over 40 to some degree.
Wow.
It often occurs when those parasympathetic nerves don't release enough NO. While, psychological factors, alcohol, certain drugs can cause temporary ED, chronic issues often stem from underlying hormonal, vascular, or nervous system problems.
And those drugs like Viagra.
Right. Drugs like Viagra, Cialis, they work by essentially potentiating or boosting the effect of any existing NO. They help relax the smooth muscle, making it easier to get and maintain blood flow.
I see. And when we talk about ejaculation, how does that process differ from erection? Is it the same system?
No, it's different. Unlike erection, which is parasympathetic, ejaculation is under sympathetic control.
That's sympathetic.
Right? It's a spinal reflex. It causes the bladder sphincter muscle to constrict, very important, prevents urine release or semen refluxing into the bladder.
Makes sense.
Then the reproductive ducts and glands contract forcefully, emptying their contents into the urethra. Finally, rhythmic contractions of muscles at the base of the penis propel the semen out.
And quite forcefully, right?
Oh, yeah. Speeds can reach up to 500 centimeters per second or 5 meters per second. Quite remarkable.
That entire event is called climax or orgasm.
Yeah.
And afterward, there's that refractory period, which you mentioned lengthens with age, where another orgasm isn't immediately possible.
That's correct. A period of resolution follows.
Now, let's get into spermatogenesis, the actual process of sperm formation. You said it occurs continuously from puberty onward. That's incredible output.
It really is. A healthy adult male can produce, up to 400 million sperm daily.
Wow.
And what's truly fascinating here is that sperm formation involves meiosis. This is a special kind of cell division unique to gametes, to sex cells.
Okay, meiosis, not mitosis.
Right. Instead of simply replicating chromosomes like in mitosis, meiosis reduces the chromosome number by half from the normal 46, the diploid number, down to 23, the haploid number.
And that's critical for it.
It's absolutely crucial because when a sperm with 23 chromosomes fuses with an egg, also with 23, you reestablish that normal human diploid number of 46 in the offspring.
Perfectly restores it.
Exactly.
And meiosis also introduces incredible genetic variation, doesn't it?
Precisely. That's one of its key features. It involves 2 rounds of division. And during the first one, there's this process called crossover. Homologous chromosomes pair up and literally exchange segments of genetic material.
Like shuffling the deck.
Exactly like shuffling the genetic deck. It effectively scrambles the parental genes, ensuring that each of the 4 sperm resulting from one precursor cell is genetically unique. It massively contributes to the diversity of our species.
So, briefly, what are the steps involved in making a sperm cell?
Okay, well, it starts with stem cells in the seminiferous tubules called spermatogonia. They divide by mitosis. Some stay as stem cells. Others become primary spermatocytes destined for meiosis.
Right.
These primary spermatocytes then undergo meiosis I to form 2 secondary spermatocytes. These then quickly go through meiosis II to produce a total of 4 haploid cells called spermatids.
But spermatids aren't functional sperm yet, are they?
No, not yet. These spermatids then undergo a final maturation process called spermatogenesis. They basically streamline themselves.
How so?
They elongate, shed most of their excess cytoplasm, form a tail, the flagellum, for swimming.
So they literally pack lightly for their journey.
Exactly. They pack lightly. The resulting sperm, or spermatozoon, has a head containing the nucleus and an acrosome cap. Yeah, it's like a helmet full of enzymes needed to penetrate the egg.
Mm.
Then there's a mid-piece packed with mitochondria, the powerhouses, providing energy for the tail, and then the long tail itself for propulsion, ready for the journey.
When it comes to male fertility, what are some of the key factors or potential issues?
Well, infertility affects a significant number of couples. Maybe 1 in 7 seek treatment. Often it's linked to issues with sperm quality or quantity.
Hmm.
And there's some evidence suggesting a decline in male fertility over the past 50 years or so. Potential culprits include environmental toxins, maybe things with estrogen-like effects, certain antibiotics, radiation, heavy metals.
Lifestyle factors, too.
Yeah, things like marijuana use, excessive alcohol, hormonal imbalances, and even thermal factors like prolonged high fevers or maybe even frequent hot tub use can impact sperm production.
How is this entire complex process from hormone release to sperm production actually regulated?
It's governed by a really sophisticated three-tiered communication system. It's called the hypothalamic pituitary gonadal axis, or HPG axis.
HPG axis.
Right. So the hypothalamus, that's in the brain, it's at the top. It releases gonadotropin-releasing hormone, or GnRH.
Non-RH.
That GnRH travels down to the anterior pituitary gland, signaling it to release 2 other hormones: follicle-stimulating hormone, FSH, and luteinizing hormone, LH.
FSH and LH. And what do these two do specifically in males?
Good question. FSH primarily acts indirectly. It stimulates those nurse cells, the cystenocytes, to release something called androgen binding protein, or ABP.
ABP.
Yeah, and ABP helps keep the local concentration of testosterone high right where the sperm are forming, which is essential for spermatogenesis.
Okay, so FSH supports sperm production indirectly. What about LH?
LH targets the other key cells in the testes, those interstitial endocrine cells, the Leydig cells. LH basically prods them to secrete testosterone.
So testosterone is truly the master hormone here for males.
It really is. Rising testosterone levels are critical. They not only fuel spermatogenesis itself, but they also drive the maturation of the male reproductive organs during puberty, the development of secondary sex characteristics, body hair, deeper voice, increased muscle mass.
Libido, too.
And boost libido, yes. Crucially, though, as testosterone levels rise, they send a negative feedback signal back up to the hypothalamus and the pituitary.
Telling them to slow down.
Exactly. It inhibits the release of GnRH, FSH, and LH, keeping the whole system in a stable balance. There's also another hormone, inhibin, from the cystenocytes, that specifically dials back FSH when sperm count is high. It's a finely tuned system.
Wow. Okay, that's a great overview of the male system. Now let's shift gears to the female side, which, as you said, is far more complex, not just for egg production, but for potentially nurturing a developing fetus for months.
Absolutely. A whole different level of complexity.
Let's start with the ovaries, the femogonads, the egg bank. What's inside them?
So each ovary has an outer cortex, where the action happens, and an inner medulla. Embedded in that cortex are the ovarian follicles. These are tiny sac-like structures. And each follicle contains an immature egg, an oocyte, surrounded by one or more layers of supporting cells, follicle cells, or granulosa cells.
And these follicles mature over time.
Yes, they go through various stages. They start as primordial follicles, then develop into primary, then secondary follicles. Eventually, one becomes a fully mature vesicular or antral follicle, which has this characteristic fluid-filled cavity called an antrum.
And what happens when a follicle is fully mature? Ovulation.
Exactly. In an event called ovulation, typically just one of these mature follicles ruptures, ejecting its oocyte from the ovary. And after ovulation, that ruptured follicle transforms into something called the corpus luteum.
A corpus luteum.
Right, it becomes a temporary endocrine gland, a hormone factory, basically.
Now, unlike the male system where the ducts are continuous, the female duct system isn't physically connected to the ovaries. So how does that ovulated oocyte actually get captured by the uterine tube? It seems precarious.
It does, but it's a remarkably effective capture mechanism. The uterine tubes, also called fallopian tubes, have these open, funnel-shaped ends called the infundibulum, and these ends have ciliated, finger-like projections called fibrae that sort of drape over the ovary.
Okay.
Around the time of ovulation, the fimbriae stiffen and actively sweep the ovarian surface. Plus, the beating of their cilia creates fluid currents that literally draw the oocyte into the uterine tube.
Wow, like a little vacuum cleaner.
Sort of. And once inside, muscular contractions, peristalsis in the cilia gently move the oocyte along towards the uterus. And this tube, this is also crucially where fertilization typically occurs.
That sounds incredibly precise, but also vulnerable, as you mentioned. What are the clinical implications of this non-continuous system?
You're right, it does create specific risks. One major one is ectopic pregnancy. That's where a fertilized egg implants outside the uterus, most often right there in the uterine tube. That can be very dangerous, even life-threatening.
Right.
It also makes women more susceptible to pelvic inflammatory disease, or PID. Sexually transmitted microorganisms can potentially travel up from the vagina, through the uterus, and out the open ends of the tubes into the pelvic cavity.
Causing infection and scarring.
Yes, potentially causing scarring of the uterine tubes and ovaries, which is a major cause of infertility.
Okay, now to the uterus, the womb. This remarkable hollow organ that receives, retains, and nourishes a fertilized egg. It has a main body, a fundus at the top, and the cervix at the bottom, which projects into the vagina.
Correct, and the cervix is quite important. It has cervical glands that secrete mucus. Normally, this mucus is thick and forms a plug, acting as a barrier to block bacteria and, most of the time, sperm.
Except mid-cycle.
Exactly. Around mid-cycle, when ovulation is near, rising estrogen levels cause the mucus to thin dramatically, creating channels that help sperm passage into the uterus.
And speaking of the cervix, what about cervical cancer? That's something we hear a lot about.
Yes. Cervical cancer is most common in women aged, say, 30 to 50. A huge risk factor is infection with certain strains of the human papillomavirus, or HPV.
HPV.
Right. The good news is that the pap smear is a highly effective screening tool for detecting precancerous changes very early, when this slow-growing cancer is highly treatable. And even better, the Gardasil vaccine now offers crucial prevention against the main HPV types that cause cervical cancer.
That's a major advance. Now let's look closer at the uterine wall itself, because it's so dynamic, constantly changing.
It really is. The uterine wall has 3 layers. There's the outer perimetrium, which is just connective tissue. Then the really thick muscular middle layer, the myometrium. This is smooth muscle that contracts powerfully during childbirth. And then the inner mucosal lining, the endometrium. This is the layer where a fertilized embryo would implant and develop.
And that endometrium itself has 2 layers, right? The functionalis and the basalis.
Correct. The endometrium has a deeper stratum basalis, which is permanent and rebuilds the layer above it after menstruation. And then the stratum functionalis, the functional layer, this is the layer that undergoes those dramatic cyclic changes in response to hormones and is shed during menstruation if pregnancy doesn't occur.
And its blood supply is key to that shedding.
Absolutely. It has unique spiral arteries within the stratum functionalis. Towards the end of the cycle, if pregnancy hasn't occurred, falling hormone levels cause these arteries to spasm, cutting off the blood supply. This causes that functional layer to die, and then it's shed during menstruation.
Fascinating mechanism. Finally, for the internal anatomy, the vagina, often called the birth canal. What are its key features?
Right. It's a thin-walled muscular tube extending from the cervix down to the body exterior. Its inner lining, the mucosa, has these transverse ridges called rugae. Yeah, they provide friction, which helps stimulate the penis during intercourse. Interestingly, the vagina doesn't have glands itself. It relies on mucus from the cervical glands above, and also a sweating process from its own walls for lubrication during arousal.
And it's acidic.
Yes, its normal pH is quite acidic. This is maintained by resident bacteria that metabolize glycogen, released by the vaginal cells, into lactic acid. This acidity helps prevent infections, but it's actually hostile to sperm, which is why the alkaline semen is so important for sperm survival.
Moving beyond the internal anatomy, what about the external genitalia, collectively called the vulva?
Okay, the vulva includes structures like the mons pubis, the labia majora and minora, and the clitoris. Interestingly, there are homologies here with the male system.
Homologies, like shared origins.
Exactly. The labia majora are homologous to the male scrotum. The labia minora are homologous to the ventral part of the penis. And the clitoris, which is largely composed of erectile tissue, is homologous to the male penis.
So the clitoris also becomes engorged.
Yes, during sexual stimulation, the clitoris becomes engorged with blood, becoming more prominent and sensitive, playing a key role in female sexual arousal and orgasm.
Mammary glands are also considered a key female accessory reproductive organ, right? Though they're technically modified sweat glands.
That's correct. They are present in both sexes, but typically only function in females after childbirth to produce milk for nourishing the infant lactation.
What's the internal structure?
Each breast contains about 15 to 25 lobes, arranged radially around the nipple. Within these lobes are smaller lobules containing the glandular alveoli. These are the tiny sacs that actually produce milk when a woman is lactating.
Uh-huh.
Milk then passes into lactiferous ducts, which converge and open individually at the nipple. It's important to note, though, that breast size in non-pregnant, non-lactating women is largely determined by the amount of fat deposited around the glandular tissue, not the amount of glandular tissue itself.
And breast cancer, unfortunately, is a very significant health concern for women.
It is indeed. It's the most common malignancy and the second leading cause of cancer death in U.S. women. It usually arises from the epithelial cells lining the smallest ducts.
Are there known risk factors?
There are several risk factors, including a family history, certain inherited gene mutations like BRCA1 and BRCA2, early menarche, late menopause, having no pregnancies or a first pregnancy late in life. However, it's crucial to know that over 70% of women who develop breast cancer have no known risk factors.
That's sobering. So screening is key.
Absolutely. Regular screening, typically involving mammography, sometimes MRI, is vital for early detection when treatment is most effective. Treatments can range from surgery and radiation to chemotherapy and hormone-blocking drugs, depending on the type and stage.
Okay, so that covers the anatomy. Let's delve into the female physiology, which is really different from the male, particularly gamete production. It's cyclic, not continuous, and starts before birth.
That's right. Oogenesis, or egg formation, is quite different. It actually begins in the female fetus. Euploid stem cells in the fetal ovary, called oogogonia, multiply rapidly by mitosis. Then they transform into primary oocytes.
Primary oocyte.
These primary oocytes then begin their first meiotic division, but they get stalled or arrested in a specific stage, prophase I, and they stay stalled there.
So a female is born with her entire lifetime supply of potential eggs already started in meiosis.
Exactly. She's born with roughly 1 million of these primary oocytes, already stalled in meiosis the first. That's her lifetime supply. No more are made after birth. They just sit there, quiescent, for years, even decades.
Wow. And what happens after puberty?
After puberty, each month, in response to hormones, a small cohort of these follicles containing primary oocytes starts to develop. Usually, only one follicle outcompetes the others and is selected to become the dominant follicle.
Okay.
Just before ovulation, the primary oocyte within this dominant follicle finally completes meiosis the first, but the division is unequal.
Unequal? How so?
It produces one very large cell, the secondary oocyte, which gets almost all the cytoplasm, and one tiny cell called the first polar body, which is essentially just a packet of chromosomes and will degenerate.
So the secondary oocyte is what's ovulated.
Yes. And the secondary oocyte then begins meiosis the second, but it gets arrested again, this time in metaphase 2. This arrested secondary oocyte is the cell that is actually ovulated.
So it's not even a fully functional ovum yet when it's released from the ovary.
Correct. It's still technically arrested in meiosis. The secondary oocyte only completes meiosis the second if and only if a sperm penetrates it.
Ah, fertilization triggers the final step.
Exactly. Sperm penetration prompts the secondary oocyte to quickly complete meiosis the second, resulting in one large ovum, the functional egg now ready to fuse its nucleus with the sperms, and another tiny second polar body, which also degenerates.
This is a massive contrast to spermatogenesis, which yields 4 viable functional sperm from each precursor cell.
It absolutely is. Oogenesis results in only one functional ovum and 3 tiny non-functional polar bodies that are basically discarded genetic material. This very unequal cytoplasmic division is crucial, though. It ensures that the fertilized egg, the zygote, has ample nutrients and organelles to support its early development before it implants in the uterus.
Makes sense. But you also mentioned a higher error rate.
Yes, unfortunately, the error rate in meiosis, particularly in distributing chromosomes correctly, is significantly higher in oocytes compared to sperm. It's estimated that maybe up to 20% of oocytes might have an incorrect chromosome number, which is a major cause of miscarriage and certain genetic disorders.
Okay, so this monthly series of events in the ovary leading to ovulation is called the ovarian cycle. You mentioned it has 2 main phases.
That's right. The ovarian cycle is typically described over about 28 days, though it varies. It's divided into the follicular phase and the luteal phase.
Follicular phase first.
Right. The follicular phase usually spans from day 1 to about day 14. This is the period when that cohort of follicles is growing, one becomes dominant, and crucially, this dominant follicle starts secreting significant amounts of estrogens. Ovulation typically occurs around day 14, marking the end of the follicular phase.
And the luteal phase?
The luteal phase runs from about day 14 to day 28. This is the period when the corpus luteum formed from the ruptured follicle is active and secreting hormones, primarily progesterone and some estrogens.
You mentioned cycle length varies.
Yes. While the textbook cycle is 28 days, only about 10–15% of women actually have a precise 28-day cycle. The main source of variability is usually the length of the follicular phase. The luteal phase, however, is remarkably constant, almost always 14 days from ovulation until the end of the cycle, unless pregnancy occurs.
So during the follicular phase, a group of follicles starts growing, but usually only one makes it to dominance. Then, just before ovulation, the primary oocyte inside completes meiosis III.
Yes, that sets the stage. Ovulation itself is the physical event where the ovary wall ruptures, expelling that secondary oocyte, usually surrounded by some granulosa cells, into the peritoneal cavity near the fallopian tube opening.
Is that sometimes felt?
Some women do experience a twinge of pain on one side around the time of ovulation, sometimes called Mittelschmerz, which means middle pain in German.
And twins.
Right. In about 1–2% of ovulations, more than one oocyte might be released, usually if more than one follicle reaches maturity. If both are fertilized, this results in fraternal or non-identical twins.
Okay. And after ovulation, what happens to that ruptured follicle again? The corpus luteum.
Exactly. The remnants of the ruptured follicle transform into this glandular structure, the corpus luteum, which literally means yellow body. It immediately starts churning out large amounts of progesterone and also some estrogens.
And its fate depends on pregnancy.
Correct. If no pregnancy occurs, the corpus luteum starts degenerating about 10 days after ovulation. Its hormone production plummets, and it eventually becomes just a small scar on the ovary called the corpus albicans, white body. This drop in hormones triggers menstruation.
But if pregnancy does occur?
If pregnancy occurs, the developing embryo starts producing a hormone that signals the corpus luteum to stick around. It persists, continuing to produce progesterone and estrogen, which are essential for maintaining the early pregnancy, until the placenta develops enough to take over hormone production, usually after a couple months.
Wow, such intricate timing. How are these complex female cycles regulated? It must involve that HPG axis again.
It absolutely does. Similar to males, it's the hypothalamic pituitary gonadal axis orchestrating everything, with GnRH from the hypothalamus, FSH and LH from the pituitary, and ovarian hormones, estrogens and progesterone, providing feedback.
Any difference in what triggers puberty?
It's interesting, the onset of puberty in females seems to be linked, at least partly, to the amount of adipose tissue, or body fat. A hormone called leptin, which is released by fat cells, appears to signal to the hypothalamus whether the girl has sufficient energy stores to potentially support a pregnancy. If leptin levels are too low, puberty might be delayed.
Fascinating connection.
Yeah.
So walk us through the key hormonal interactions during a typical ovarian cycle.
Okay, so day 1, menstruation starts, hormone levels are low. The hypothalamus starts releasing GnRH.
Right.
GnRH stimulates the anterior pituitary to release FSH and LH. FSH, primarily, stimulates several follicles to start growing and maturing. LH also helps follicle development and prods certain cells, the follicle cells, around the follicle to produce androgens.
Androgens in females.
Yes, but these androgens are then quickly converted into estrogens by the granulosa cells within the follicle, stimulated by FSH. So as follicles grow, estrogen levels start to rise.
Okay, rising estrogen. And this is where the female regulation really diverges from the male, isn't it? That unique positive feedback loop.
Exactly. This is the critical difference. Initially, as estrogen levels rise moderately, they exert negative feedback on the pituitary and hypothalamus, mostly inhibiting FSH release. This helps ensure usually only one follicle becomes truly dominant.
But then,
as the dominant follicle grows larger and pumps out more and more estrogen, once estrogen levels reach a critical high concentration and stay high for a certain period, they suddenly flip the switch. They exert positive feedback on the brain and pituitary.
positive feedback. And that positive feedback causes what?
It causes a sudden, massive surge of LH release from the pituitary. A smaller FSH surge happens too, but the LH surge is the main event.
The LH surge. And this is the trigger for it.
This LH surge is the master signal. It does several things rapidly. It prompts the primary oocyte in the dominant follicle to finally complete meiosis first. It triggers the events leading to the rupture of the follicle wall ovulation about 24–36 hours later, and it then transforms the remnants of that ruptured follicle into the corpus luteum.
Wow, so LH surge ovulation, corpus luteum formation.
Precisely. And LH then also stimulates this newly formed corpus luteum to start producing large amounts of progesterone, along with estrogen.
Okay, now we have high progesterone and estrogen post-ovulation. What effect do they have?
These rising progesterone and estrogen levels, particularly the progesterone, now exert strong negative feedback back on the hypothalamus and pituitary. This suppresses the release of GnRH, LH, and FSH.
Why suppress them now?
This prevents any new follicles from starting to mature during the luteal phase. You don't want another ovulation happening if pregnancy might be underway. It keeps things quiescent until the fate of the current cycle is determined. If no fertilization, the corpus luteum degenerates, hormone levels crash, the negative feedback is lifted, and GnRH, FSH, LH can rise again to start a new cycle.
Such an elegant, if complex, dance of hormones. And this hormonal dance leads us directly to the changes in the uterus, the uterine or menstrual cycle, right? It's responding to these ovarian hormones.
Exactly. The uterine cycle mirrors the ovarian cycle and is driven entirely by the fluctuating levels of estrogen and progesterone produced by the ovaries. It has three distinct phases.
Phase 1.
First, the menstrual phase. This typically corresponds to days 1 to 5 of the cycle. Ovarian hormones, estrogen and progesterone, are at their lowest levels because the old corpus luteum has degenerated. Without hormonal support, that stratum functionalis of the endometrium detaches and is shed, accompanied by bleeding.
Okay, menstruation. Then what?
Then comes the proliferative or preovulatory phase. This usually corresponds to days 6-14, overlapping with the ovarian follicular phase. As the new follicles develop, rising estrogen levels stimulate the stratum bassalis to regenerate the stratum functionalis. The endometrium rebuilds itself, becomes thicker, glands enlarge, blood vessels increase. Estrogen also causes that cervical mucus to thin. Ovulation occurs at the very end of this phase, around day 14.
And the final phase.
Finally, the secretory or post-ovulatory phase. This corresponds to days 15-28, overlapping with the ovarian luteal phase. Now, rising progesterone levels from the corpus luteum act on the estrogen-primed endometrium. It causes the glands to enlarge further and begin secreting nutrients like glycogen into the uterine cavity. The blood supply increases even more. Essentially, the endometrium is fully prepared for an embryo to implant.
And the cervical mucus.
Progesterone also causes the cervical mucus to become thick and viscous again, forming that protective cervical plug. If fertilization and implantation don't occur, the corpus luteum degenerates, progesterone levels plummet around day 25-26, those spiral arteries spasm, the endometrial cells die, and the functional layer breaks down, leading to menstruation and the start of a new cycle on day 1.
Incredible cycle.
Yeah.
Any clinical implications related to this delicate female cycle, particularly, say, related to physical activity?
Yes, that's an important point. Extremely strenuous physical activity, especially if combined with low body fat, can significantly disrupt the cycle. It can delay menarche, the first period, in adolescent girls, and in adult women, it can cause irregular cycles or even amenorrhea, the complete cessation of menstruation.
Why does that happen?
It's often linked back to those energy stores and leptin levels we mentioned. Very low body fat can lead to low leptin, which the hypothalamus interprets as insufficient energy reserves for reproduction. So it dials down the HPG axis, suppressing GnRH, FSH, and LH release, and the cycles stop.
Are there health consequences beyond reproduction?
Yes, a very concerning one. Because estrogen levels plummet in this situation, women experiencing athletic amenorrhea can suffer significant bone mass loss, similar to what happens after menopause. It puts them at risk for stress fractures and osteoporosis later in life. It's not just about fertility.
That's important to know. And what are the broader impacts of estrogens and progesterone on the female body, beyond just the reproductive organs and cycles?
Oh, they have widespread effects. Estrogens promote the female growth spurt during puberty, but also cause earlier closure of the epiphyseal plates, resulting in generally shorter stature than males. They contribute to female skeletal characteristics like a wider pelvis. They famously influence fat depositions more in the hips, breasts, and buttocks.
Cardiovascular health, too.
Yes, estrogens generally have a beneficial effect on cholesterol levels, helping maintain low total cholesterol and high HDL, the good cholesterol. They also facilitate calcium uptake, helping maintain bone density throughout reproductive life.
And progesterone.
Progesterone primarily works in concert with estrogen to regulate the uterine cycle, as we saw. It also causes those changes in cervical mucus. During pregnancy, it's absolutely vital. It helps maintain the uterine lining, inhibits uterine motility, preventing premature contractions, and helps prepare the breasts for lactation.
Okay, now let's briefly turn to sexually transmitted infections, or STIs. These are a major public health concern, impacting the reproductive system directly.
They absolutely are. STIs, sometimes called STDs, are infectious diseases spread primarily through sexual contact. The U.S., unfortunately, has very high rates compared to other developed countries, and STIs are the single most important cause of reproductive disorders, including infertility.
Prevention is key then.
Prevention is paramount. Consistent and correct use of barrier methods like latex condoms significantly reduces risk, though it's not 100% effective for all STIs. It's also important to know that while bacterial STIs were historically the main concern, viral STIs are now incredibly widespread and often incurable.
Can you give us a quick rundown of some common ones mentioned in the chapter, bacterial first?
Sure. Gonorrhea, caused by Neisseria gonorrhea, often causes painful urination and discharge in men, but frequently asymptomatic in women, which is dangerous because untreated infection can lead to severe PID and sterility. Syphilis, caused by Treponema pallidum, a tricky one that progresses through stages. A painless sore, chancre, then a rash, then a latent period, and potentially devastating tertiary syphilis affecting organs years later. Treatable with penicillin, especially early on. Chlamydia, this is often called a silent epidemic.
Why silent?
Because it's the most common bacterial STI in the U.S. and is asymptomatic in up to 80% of women. Yet, it's a major cause of PID and sterility. In men, it can cause urethritis, easily treated with antibiotics if diagnosed. Trichomoniasis is actually a parasitic infection, very common, especially in young women, often asymptomatic but can cause discharge and irritation, curable with medication.
And the viral STIs.
Key viral ones include genital warts, caused by the human papillomavirus, HPV. There are many strains. Some cause warts, while others are high risk and significantly increase the risk for various cancers, most notably cervical cancer. This makes the HPV vaccine incredibly important for prevention. Warts can be treated, but the virus often causes recurrences.
And herpes.
Right. Genital herpes, usually caused by herpes simplex virus 2, HSV2, though HSV1 oral herpes can also cause it. These viruses are notoriously difficult to control. They establish lifelong latent infections in nerve ganglia, remaining silent for long periods before reactivating to cause recurrent, often painful, blister-like lesions. It's extremely prevalent. While antiviral drugs can help manage the frequency and severity of outbreaks, they cannot cure the infection. The virus remains in the body for life. Congenital herpes passed to a baby during birth can be very severe.
A serious list. Okay, let's wrap up by looking briefly at how this intricate system develops, from conception through to the later stages of life.
Sounds good. It starts right at fertilization. Genetic sex is determined then and there by the sex chromosome carried by the sperm. If the sperm carries an X chromosome, the resulting zygote is XX genetically female. If it carries a Y chromosome, the zygote is XY genetically male.
And that Y chromosome carries the master switch.
Exactly. There's a specific gene on the Y chromosome called the SRY gene, sex-determining region Y. If present and functional, the SRY gene initiates the development of tests in the embryo, setting in motion the entire cascade of male development. Without SRY, the gonads develop into ovaries by default.
What happens if there's a mix-up in these sex chromosomes during meiosis, like an extra one or a missing one?
That can lead to significant issues. Abnormal combinations due to chromosomal non-disjunction can occur. For example, Turner syndrome results from having only one X chromosome, XO. These individuals are genetically female, but their ovaries never develop properly, leading to sterility and other developmental issues. Klinefelter syndrome results from having an extra X chromosome, XXY. These individuals are genetically male, but the tests are underdeveloped, they are typically sterile, and may have some female-like characteristics. These conditions highlight just how critical the correct chromosome complement is for normal sexual development.
It's fascinating that the early embryo actually starts in a sexually indifferent stage, isn't it? With structures that could become either male or female.
It absolutely is. For the first 6 or 7 weeks, the embryo has both sets of primitive duct systems. The mesonephric, or Wolffian ducts, which can become the male ducts, and the paramesonephric, or Mullerian ducts, which can become the female ducts. Uterine tubes, uterus, part of the vagina. The external genitalia are also bipotential initially.
So what determines which path is taken?
It all hinges on the presence or absence of testosterone produced by the developing gonads. If the SRY gene triggers testis development, these embryonic tests start producing testosterone relatively early. Testosterone stimulates the mesonephric ducts to develop into the male reproductive tract, epididymis, ductus deferens, etc., and also causes the external genitalia to develop into a penis and scrotum. The testes also produce another hormone, Müllerian inhibiting substance, MIS, which causes the female Müllerian ducts to degenerate.
And if there are no testes, no testosterone.
In the absence of testosterone and MIS, the female pathway proceeds by default. The Müllerian ducts develop into the uterine tubes, uterus, and upper vagina, while the mesonephric ducts degenerate. The external genitalia develop into the clitoris, labia, etc. It's the presence of testosterone that actively drives male development. Female development is the default pathway in its absence.
So a genetic male who couldn't produce or respond to testosterone would develop
female accessory structures and female external genitalia, despite having XY chromosomes and non-functional tests internally. Conversely, if a genetic female fetus were exposed to high levels of testosterone at the critical time, say from an overactive adrenal gland or medication taken by the mother, she could develop male ducts and external genitalia. Individuals whose external genitalia don't match their genetic or gonadal sacs are sometimes referred to as pseudohermaphrodites.
Wow. And the descent of the gonads, that's another key developmental event, right? Especially for males.
Yes. The testes initially develop high up in the abdominal cavity near the kidneys. Then, usually around the 7th month of fetal development, they begin their descent, guided by a fibrous cord called the gubernaculum, down through the inguinal canal into the scrotum. This descent is stimulated by fetal testosterone.
And the ovaries.
The ovaries also descend, but only partway, ending up in the pelvic brim, not outside the body cavity.
And if the testes don't descend properly, that's cryptorchidism again.
Exactly. Cryptorchidism, or undescended tests, is relatively common in premature infants, but usually resolves on its own. If one or both tests fail to descend by early childhood, it's a problem because the higher temperature inside the body inhibits sperm production, leading to sterility. It also significantly increases the risk of testicular cancer later in life. Surgical correction is usually performed in early childhood to bring the testes down into the scrotum.
Okay, moving past fetal development, puberty is the next major milestone. This is when the reproductive organs grow to adult size and become fully functional.
Right. Puberty is that period of transition from childhood to adulthood. It's triggered by the reactivation of the HPG axis, leading to rising levels of gonadal hormones, testosterone in males, estrogens in females.
What are the typical signs and timing?
In males, puberty typically begins between ages 8 and 14. The first sign is usually enlargement of the testes and scrotum, followed by growth of the penis. Secondary sex characteristics appear pubic, axillary, and facial hair. Deepening voice, increased muscle mass. Mature sperm production usually begins around age 14.
And in females?
In females, puberty usually starts a bit earlier, between ages 8 and 13. The first sign is typically breast development, the larche. This is followed by the appearance of pubic and axillary hair. Then comes menarche, the first menstrual period, which usually occurs about 2 years after the onset of puberty. However, it's important to note that the first few cycles are often anovulatory, no egg released. Reliable ovulation and full fertility typically take a few more years after menarche to become established.
Okay, so the system activates at puberty. What happens at the other end of reproductive life as we age?
Well, the aging process affects the reproductive system differently in males and females. In women, ovarian function starts to gradually decline surprisingly early, even from the late 20s onward. The number of viable follicles decreases, and the remaining ones become less responsive to FSH and LH, leading eventually to menopause. As women reach their late 40s or early 50s, the supply of functional follicles dwindles. Estrogen production drops significantly, cycles become irregular and often anovulatory, and finally, menstruation ceases altogether. Menopause is defined as the point when a woman has gone 12 consecutive months without a menstrual period. The average age is typically between 46 and 54.
And what are the impacts of this drop in estrogen after menopause?
The decline in estrogen can have significant effects. The reproductive organs and breasts may atrophy somewhat. The vaginal lining can thin and become dry, sometimes making intercourse uncomfortable. Many women experience hot flashes due to vasomotor instability. There can also be increased risk for cardiovascular disease, as estrogen's protective effects are lost, and accelerated bone loss, potentially leading to osteoporosis.
What about hormone replacement therapy, HRT?
HRT was once widely prescribed to alleviate menopausal symptoms and prevent bone loss. However, large clinical trials revealed that, for some formulations and durations, HRT could increase the risk of heart attack, stroke, blood clots, and breast cancer in certain women. So, current guidelines generally recommend using the lowest effective dose for the shortest possible time, primarily for managing severe symptoms, and decisions are highly individualized based on risk factors.
Okay. And for men, Is there an equivalent to menopause?
No, there's no abrupt cessation of reproductive function in males comparable to menopause. Healthy men can often remain fertile and father children well into their 70s or even 80s.
But does function decline at all?
Yes, there is a gradual decline. While testosterone levels don't plummet suddenly like estrogen does in women, there is typically a slow, steady decrease in testosterone secretion with age. This is sometimes referred to as andropause, though it's a much milder and more gradual condition than menopause. Men may experience effects like a longer refractory period after orgasm, reduced sperm motility, and perhaps subtle changes in mood or energy, but usually not a complete shutdown of reproductive capability.
So reflecting on this whole system,
What's truly remarkable about the human reproductive system, I think, is its dual uniqueness. First, as we said, it's largely non-functional, just waiting for the first decade or more of life. And second, unlike any other organ system, it's uniquely designed to interact intimately with another individual system to achieve its ultimate biological purpose, the conception, development, and birth of new life. It's quite profound when you think about it.
it really is. And that concludes our deep dive into the human reproductive system, guided by Chapter 27. We've covered its incredible anatomy, the precise physiological processes like sperm and egg formation, the complex hormonal dances that regulate our cycles, and even key developmental aspects and common clinical challenges.
It's a system of absolutely remarkable complexity and adaptability, constantly balancing these intricate biological processes to ensure the continuation of life. It truly makes you marvel at the human body's intricate design.
We sincerely hope this deep dive has given you a clearer understanding, maybe answered some questions, and perhaps sparked even more curiosity about your own body's incredible design. Thanks so much for joining us for this shortcut to being well-informed.
Yes, thank you for listening.
And thank you, as always, for being a part of our last-minute lecture family.